respected senior colleagues and respected chairperson, Dr. Swami sir, for your kind words introducing the topic personalizing and optimizing lipid lowering therapy, especially in diabetics population. See, the diabetes is a silent killer. You all know that the number of the diabetics are increasing like anything. What is more important is 90% of the diabetics are having atherogenic dyslipidemia. Not only the diabetics, nearly 70 to 80% of the pre-diabetics are also having the dyslipidemia. So, in all the diabetic individuals, we should give a lot of respect to the dyslipidemia management so that the complications of the diabetes will be reduced by proper management of the dyslipidemia. What about the prevalence of the dyslipidemia in diabetes? See, the dyslipidemia in diabetes is about 2 times higher than that of people without the diabetes. So that clearly shows that more the diabetes, more the hyperglycemia, more the lipids. And you all know that the LDL levels, the target levels have come down. Earlier it was 130, later it's 100, and then the 70. Even nowadays, even the 50 or the 35 is the goal of the LDL-C cholesterol in most of the uncontrolled diabetics and people with atherosclerotic cardiovascular disease. If you see that, if your target is at 100 milligrams, I think 85% of the people with diabetes had the dyslipidemia. And if your target is a 70, maybe 95%. If your target is 50, almost 100% of the diabetics are dyslipidemic. Among the lipid profile, we give a lot of respect to the LDL. LDL is nothing but it is a lipoprotein, transport the cholesterol and other lipids throughout the body and play a central role in the initiation and the progression of the atherosclerosis. See why I am saying the LDL. LDL is very easily calculated in our lipid profile management profiles, whereas the apolipoprotein B, which is also very, very important atherosclerotic lipoprotein, but not being measured in routine labs, and we have to send it for the higher centers. But we can calculate the apolipoprotein B in a surrogate manner in our lipid profile values by noting your cholesterol minus HDL, that gives you the non-HDL-C cholesterol. For example, a person's cholesterol is 200 and a person's HDL is 40. So 200 minus 40, so 160 is your non-HDL-C cholesterol, and that non-HDL-C cholesterol is almost equivalent as the apolipoprotein B. So indirectly we can know what about the amount of the lipoprotein B by noting your non-HDL-C cholesterol, which is not being given your lipid profile, and you have to get the non-HDL-C cholesterol by subtracting the cholesterol minus HDL cholesterols. So therefore, maintaining the optimum lipid levels is an important component of the ideal cardiovascular health. You all agree with me that the common cause of the death in diabetes is a vascular death, whether it is a myocardial infarction or a cerebrovascular disease or a peripheral vascular disease. So you have to respect the vessels in all the diabetic individuals, and I think the lipid profiles or the lipid levels are very, very important component in doing so. So this is the risk stratification algorithm recommended by our Lipid Association of India. So our association, Lipid Association of India, is saying that there are the 5 major atherosclerotic cardiovascular disease risk factors. So what are those 5 risk factors? Main atherosclerotic cardiovascular risk factors. One is the age. Age more than 45 years in the males, more than the 55 years in the females. So in Indian population, we are getting the atherosclerotic cardiovascular in younger age group. So that is the reason. So our age limit is the 45 years in the males and 55 years in the females. When compared to the Western population, there it is about 55 in the males or 60 in the males and about 65 to 70 in the females. And the second important thing is the family history of the premature atherosclerotic cardiovascular disease. So we Indians are having the high incidence of the diabetes, hypertension and other lipid dyslipidemias, and so also atherosclerotic cardiovascular disease. So age is a non-modifiable risk factor, family history is a non-modifiable risk factor, and we have the 3 modifiable risk factors. They are the smoking and tobacco use. So the smoking cessation is a very, very important lifestyle measure to reduce the atherosclerotic cardiovascular risk. And the high blood pressure is a very common in the society. In fact, 25 to 40%, 25 to 40%, depending on the place of Indians are having the hypertension. So hypertension is a very, very big problem in the Indian population. Nearly 40 to 50 crores of Indians are hypertensive. Suppose if you see the definition of the hypertension is 140 by 90. Suppose if you take the 130 by 85 as the definition of the hypertension, I think 70 to 80 crores are hypertensive in Indian population. And the low HDLC cholesterol, that is again very important in our Indian population. We are all having the very low HDLC cholesterol in males less than the 40, in females less than the 50. So these 5 risk factors are the major atherosclerotic cardiovascular risk factors which are very, very common in our society. See the age, you can't stop your age, more than the 45 in the males, more than 55, is one risk factor is there. And the strong family history, suppose our mother or the father had a PTCA or CABG, again it's a big risk factor for us. And then the smoking is a big risk factor, and hypertension is a very common, whether you like it or not. Most of our blood pressure is systolic more than the 130 or more than the 140, and the diastolic is more than 85 or nearly than 90. So most of us are hypertensive. And HDL, again I am saying that Indians are having the low HDL. So whether you like it or not, already 4 atherosclerotic cardiovascular risk factors are there with us except the smoking. So that is our optional. And then what are the other high risk factors? Not only these, and most important other risk factors is the diabetes. So this is a very common disease, and a lot of the people, nearly the 10.5 crores are type 2 diabetes now in India, and nearly the 13.5 crores are the pre-diabetics. CKD is very common in our population. Last time we discussed about the CKD, and unfortunately, most of the CKD population are asymptomatic till they reach the stage of the 4 or the 5. Again, the CKD population, they die in the hands of the cardiologist rather than in the hands of the nephrologist because of the atherosclerotic cardiovascular disease or the heart failure or the arrhythmias or hyperkalemia, etc. So that is again the CKD is a big risk factor for the cardiac problems. Familial hypercholesterolemia, so that runs in some families with very high cholesterol levels, and extremes of a single risk factor. Coronary calcium score, so more than the 300. So some people say even the more than the 100 is a risk factor. Some people say more than the 400 is a risk factor. But the best is 0 calcium in our coronary arteries. And then the non-stenotic carotid plaque. So if you subject the patient for the carotid Doppler, so there will be intermediate thickness and the plaques will be there. That is again a risk factor. And the lipoprotein A more than the 50 is again a big risk factor. And other moderate risk, non-conventional risk factors are impaired fasting glucose. See, even though you are not a diabetic, if you are a pre-diabetic with a fasting blood sugar of 101 or 108 or 110, that is impaired fasting glucose itself is a big risk factor for the vessels. So the pre-diabetics are independent risk factor for the vascular disease. And increased waist circumference. Suppose if your waist circumference is more than 34 inches in the males and 36 inches in the females, so that means 80 and the 90 centimeters. Again, we are at high risk of getting the abdominal adiposity and visceral fat and more atherosclerotic individual. And high sensitive CRP, that is a vascular inflammation. So when the high sensitive CRP is more than the 5 is a very high risk. And if it is more than the 2, risk starts. So if you see these figures, I think most of the Indians are having the many risk factors like age, then the family history, then the blood pressure, low HDLC cholesterol, diabetes, CKD, stenosis, carotid intermediate thickness, and then the lipoproteins, calcium scores, impaired fasting glucose, waist circumference, and then the high sensitive CRP, and of course again the apolipoprotein B, that is also very high in our Indian population. So these are the very, very high risk individuals. So that is the reason, as our chairperson is saying, that lipids are very, very important for all the population and all the specialties. See, we compare the international recommendations of the diabetic dyslipidemia. What about our LAA, that is the Lipid Association of India, versus the ADA, that is the American Diabetic Association. See, the American Diabetic Association says that the primary prevention and the secondary prevention. So the primary prevention means the patient is not having any atherosclerotic cardiovascular disease. Secondary prevention means already had an attack of angina or the PTCA or the CABG or CVA. Then you to prevent the further attacks, so we use the drugs that is secondary prevention. See the primary prevention. Those people who are the diabetics, aged between the 40 and the 75 years, they need medium intensity statin therapy. So all the diabetics between 40 to 75 years. So the diabetes between 20 to 40 years of the age group. So young onset diabetes. They also need statins. So provided they have an additional atherosclerotic cardiovascular risk factors. So the being in Indian itself is a big atherosclerotic cardiovascular risk factor, families, etc. So our diabetics, even at the age of 20 and 40 years, also they need a statin. See, the diabetes patients at higher risk, especially those with multiple risk factors, again they need high sensitive, high intensity statins therapy. So these are all the primary prevention. If you see the primary prevention, one thing is very clear that all of our diabetes population, they need primary prevention. Whether they are having a family history or no family history, whether they are obese or non-obese, because we are all at high risk of getting the vascular diseases. Secondary prevention, so definitely these people, they need it. A statin, not only the small dose of the statin, maybe 5 mg or 10 mg the rosuvastatin, they need nearly 20 mg or the 40 mg of the rosuvastatin or the 40 to 80 milligrams of the atorvastatin. See, let us concentrate on our Lipid Association of Indian guidelines. They say that the diabetes with one major atherosclerotic cardiovascular risk factor without target organ damage, so their LDL target is the less than the 70. Non-HDLC cholesterol target is less than the 100. I told you what you mean by the non-HDLC cholesterol. That means cholesterol minus HDL. So this is less than the 100. When your LDL target is 70, non-HDLC target is 70 plus 30. That is 100. Suppose your LDL target is the 50, then the non-HDLC target is 50 plus 30, 80. So that's how you have to know the target of your non-HDLC cholesterol depending on your LDL goal. So these are all the our association remarks. See, another important thing here is diabetes 2 or major atherosclerotic cardiovascular risk factors. Their target of the LDL is less than 50. See, non-HDLC cholesterol target is 50 plus 30, so 80. Again, at very high risk individuals, even the LDL cholesterol less than the 30 is also possible. So the take home point from today's talk is, don't be happy with your LDL cholesterol is less than the 70. Even you have to reach the target of the 50 or even the 30, which is very easy to say, but very, very difficult to reach those targets. So that is our Lipid Association of India targets are very, very stringent targets and very, very difficult unless you concentrate on the lifestyle measures along with the statin therapy. With only the statins, it is very, very difficult to reach these targets unless you also add the lifestyle measures like your dietary approach, your exercise, etc. etc. The treatment options continue to expand. So earlier, no drugs. So we are very fortunate that in the 2000s and 2020s, we are having many drugs. So earlier, I think no drug is available for the dyslipidemia except the niacin, which is not palatable. Lot of the nausea, vomiting, abdominal cramps, etc. In fact, that is the first lipid lowering drugs entered into the market. So then you have the resins, you have the fibrates, you have the statins, you have the cholesterol absorption inhibitors like ezetimibe and PCSK9 monoclonal antibodies. They are mostly used by the cardiologists in the ICU management when the LDL cholesterol is very, very high. So you have to use these monoclonal antibodies. So these are the different drugs. So as our chairperson is saying that right now we are having the 4 or 5 oral tablets for the use of the dyslipidemias. So one we have the statins, the second we have the fibrates, and third we have the ezetimibe, that is the cholesterol absorption inhibitor, and then we have the bempedoic acid. So that is also a good drug to reduce your LDL cholesterol that doesn't act on the triglycerides. So these are the 4 important drugs right now available in our hand, like the statins, whether the atorva or the rosuvastatin, fenofibrate, and then the ezetimibe, and then the bempedoic acid. And of course, in the patient can afford, then you can have a PCSK9 monoclonal antibodies. So they are the parenteral drugs, not the oral drugs. So this is the lipid transport. You all know that the bad cholesterol is the LDLC cholesterol and the good cholesterol the HDLC cholesterol. Unfortunately, most of the Indians are having a higher LDL and a lower HDL, which is much more dangerous as far as the vessels are concerned. On one hand, we are having the bad cholesterol more and more. On the other hand, we are having the good cholesterol low and low. So lower the good cholesterol itself is a big risk factor. And again, the increased LDL is another risk factor. So that is the reason our lipid profile is always dangerous in our Indian population. And if you see the several markers there, so there the lipids which are having the more and more protein is good cholesterol, that is the HDL cholesterol. The lipids which are having more and more cholesterol is the bad cholesterol, that is the LDL cholesterol. You can appreciate here, If you see the last one, that is the more protein, and then the center one is the phospholipid, and the red one is the cholesterol. That is the less cholesterol. So that is the HDLC cholesterol. And if you see the LDL next to that, so you will have the more cholesterol and then the less protein. So that is the LDL cholesterol. So how to improve your HDL? So by good walking, your physical activity definitely will improve your HDL. And of course, other thing is moderation of the alcohol. This is the inter-heart study. The dyslipidemia stands at the top position. If you see the risk factors to our health, risk factors to our vessels, smoking is banned, is not good, and less fruits intake is also not good. But unfortunately, Indians, they take very less fruits. They take fruits only when they admit in the hospitals. Usually, they need at least 5 servings of the fruits a day. So, which is not applicable for most of our Indian diets. Exercise is very good, but we don't do the exercise, physical activity. Alcohol is dangerous, moderation is good, hypertension is always dangerous, diabetes is dangerous, abdominal adiposity, psychological, that is your stress and strain, equally important, more risk factor for our vessels. And then if you see the lipids is much more dangerous when compared to your stress or your abdominal adiposity or your diabetes or hypertension, smoking, etc., etc. So you all agree with me that in all our individuals, along with your routine diseases, please concentrate on the lipids and please give one statin for the control of these lipids in our individuals. See, what are the objectives of the dyslipidemia management? The primary prevention and the secondary prevention. Primary prevention without an established atherosclerotic cardiovascular disease, but patient is at risk due to the presence of the multiple risk factors like smoking or family history or obesity or diabetes, hypertension, etc. They didn't have, right now they don't have any attack. So that is the primary prevention. That's much more important, not to have an attack. And of course, once the patient had an event, so that then it goes for the secondary prevention because of the established atherosclerotic cardiovascular disease. What about the relationship between the diabetes and dyslipidemia? So that is the bidirectional, because the root cause of your diabetes is insulin resistance. The root cause of your dyslipidemia is again the insulin resistance, and insulin resistance is the root cause for your metabolic syndrome. So the insulin resistance is the cause for diabetes, cause for hypertension. Insulin resistance is the cause for obesity and also the dyslipidemia. So the dyslipidemia contributes to the increased risk of the CVD in the diabetic patients. And then the diabetic dyslipidemia is a different entity. It's a triad. Number one is the increased triglycerides. Number two is the low HDL. And the number three is LDL cholesterol may be the normal or elevated. Even though they are the normal, if you see the particle of the LDL particle, it is very small and dense. So that is the meaning of your diabetic dyslipidemia. So a triad of hypertriglyceridemia, low HDL, and LDL cholesterol may be normal or abnormal. Even if it is a normal, if you see the cell of the LDL, it is very small and dense. So that is the diabetic dyslipidemia. The most likely cause of the diabetic dyslipidemia is the increased free acid flux secondary to insulin resistance. So the more the insulin resistance, more the free fatty acid. So more the free fatty acids, more the VLDL, more the triglycerides, more the apolipoprotein B. And then this VLDL will form both the HDL and also the LDL, and that's how it happens. So in uncontrolled diabetes, because of the hyperglycemia, so there will be more lipolysis, and once there is more lipolysis, so obviously you will have more free fatty acids and then all the dyslipidemias. So that is the reason if you give the insulin, the people will have a lipogenesis. They gain weight. So that is because of the arrest of the lipolysis. Whereas in uncontrolled diabetes, they will have a lipolysis. So this is the pathophysiology of the dyslipidemia of the diabetes. Increase in the triglycerides because of the reduced triglyceride clearance. So the triglyceride clearance is reduced. So that is the reason triglycerides are accumulated in the blood, leading to the hypertriglyceridemia. And lower levels of the apolipoprotein A1 and the HDLC cholesterol. So I told you the HDL cholesterol is a very good, but it's lowered in the diabetic individuals. Poor glycemic control is a very common. So again, that impairs your profiles, and definitely that causes more and more dyslipidemia. And role of the inflammation, that is the vascular inflammation, your high sensitive CRPs. So the pro-inflammatory cytokines, they all affect the HDL metabolism and reducing its ability to transport the cholesterol and prevent the LDL oxidation, which can lead to the atherosclerosis. And then role of the adipokines. So this is again very important. Again, unfortunately, most of our Indians are having the low adiponectin levels. Sorry, high is, yes, low adiponectin levels. So the low adiponectin levels is directly proportional to the early onset of the diabetes and also atherosclerotic diseases. When compared to the other apolipoproteins or apokines or cytokines, you have the leptin, you have the resistin, you have the tumor necrosis factor, interleukin 1, 6, 12, etc. So these are all increased. And the only one thing is decreased is the adiponectin level. And adiponectin level is good. So once the adiponectin level is lowered, again is a risk factor for the diabetes and also the heart cardiac problems. So the how to improve your adiponectin levels, again good exercise. So the physical activity. Again, the physical activity will improve your adiponectin levels, whereas you can reduce the other inflammatory cytokines, so that will lead to the atherosclerotic disease. So the diabetes, not only by means of your increased fatty acid flux or increased lipolysis, that also helps in abnormal triglycerides because of the reduced triglyceride clearance and also the adipokines and also the inflammations and also reduced HDL. So these are all important in the pathogenesis of your diabetic dyslipidemia. You all agree with me that diabetes is equivalent to the coronary artery disease. Several times I told you that the diagnosis of the diabetes itself is as equivalent as a fellow discharged from the ICUs with an acute myocardial infarction or from the CT unit with the diagnosis of CABG. But we don't give much importance to the diagnosis of the diabetes. But this diabetes diagnosis itself, if you see the 10 years lifespan or the 20 years lifespan or the 30 years lifespan of the diabetes and the cardiac patient, so the both are the same. And in fact, the diabetes they may die much early when compared to the post CABG fellow or post PTCA fellow. So that means that diabetes is almost like a myocardial infarction equivalent. So the effects of increasing levels of the LDL cholesterol and decreasing levels of the HDL cholesterol, the risk of the CVD events. See, if you see the left side, so as the LDL cholesterol is increases, the risk hazard ratio is increased. On the second slide, as the HDL cholesterol is lowered, again the hazard ratio is lower. So that means we need more HDL and lower low LDL. So these are the summary of the drugs. We have the statins. They act by the HMG coenzyme A reductase inhibitor. So they act mostly in the level of the liver. So they are very highly effective lipid lowering drugs. Ezetimibe, it is not highly effective. It may be the mild to the moderate. They are more effective in the presence of the statins rather than the ezetimibe alone. So that is the reason we don't prescribe the ezetimibe alone in most of our diabetic individuals unless those people are very, very resistant to the statin therapy or intolerant to the statin therapy. Otherwise, 99.9% who use ezetimibe in the presence of the statins to make the statins activity much more, and it will become moderate to the higher effective this combination of the statin and the ezetimibe. And how the ezetimibe acts? It reduces the cholesterol absorption. So mostly it acts at the level of the intestines. PCSK9 inhibitors are very, very effective drugs. Whatever amount of your LDL that will comes to the normal with these inhibitors therapy, but that is parenteral and very costly. And bile acid sequestrants, we don't use the bile acid sequestrants, but here another drug they didn't mention here is the bempedoic acid, which reduces your LDL cholesterol. So we have the statin, we have the ezetimibe, we have the bempedoic acid, and they also didn't mention here the fibrates. So the fibrates, they reduce the triglycerides. So to reduce your, that's how our drugs are there in the pain. So non-statin therapy's efficacy increases in combination with the statin and is safe to administer with the statins. So these are the comparison of the international recommends the diabetes dyslipidemia. Already I discussed it here. The one thing is very clear that our Indian society, lipid society, they say that LDL less than the 50 and also LDL less than the 30. So which is very, very difficult to reach. So that means that our Indians, we have to keep our lipids as low as possible to avoid the vascular events. See the effect of the lipid lowering drugs. So here they have given all the drugs here. See the statins, bile acid sequestrants, fibrates, niacin, ezetimibe, bamboic acid, etc. All the drugs are here available. See, they have told the three drugs there: LDL-C cholesterol, HDL-C cholesterol, and the triglycerides. If you see the drugs, all the drugs act on all the three parameters. So you should know that statins not only reduces the LDL cholesterol, they also reduce triglycerides, they also increase HDL. In the same way, if you take the fibrates, they not only reduces the triglycerides, they also reduce LDL, they also increase HDL. In the same way, if you take the ezetimibe, they not only reduce the LDL, they reduce the triglycerides and also have a minor effect on the elevation of the HDL. So this is there. But in a single word, statins, they mainly reduce the LDL-C cholesterol about 60%, 50 to 60%, and about 20 to 30%, they reduce the triglycerides and they elevate the HDL by 5 to 10%. And if you take the fibrates, about 60 to 70%, they reduce the triglycerides, maybe 20% they reduce the LDL, and maybe 10 to 15% they increase the HDL. So HDL elevation is much more with the fibrates when compared to the statins. LDL reduction is much more with the statins when compared to the fibrates. And triglyceride reduction is much more with the fibrates when compared to the statins. So this is the main difference between the statins and the fibrates as far as the reduction of your LDL, HDL and the triglycerides are concerned. And if the patient is having the mixed dyslipidemia, so already I have put one case study. Today I have seen one patient with the triglycerides 900. You can go through the WhatsApp CME group. You can have one patient Satyavati with different lipid profile values I already posted. And if you see that female is a diabetic, is having the mixed dyslipidemia. So there with the triglycerides 900 and cholesterol 200, LDL 130. So you have to use both the statins as well as the fibrates because that patient is a mixed dyslipidemia. Already my friend gastroenterologist Vamsi asked me, sir, what about the pancreatitis risk? Yes, that fellow is at risk of getting the pancreatitis because triglycerides more than the 500 is a risk for the pancreatitis. Okay, suppose if the patient is a male and an alcoholic, so definitely we have to admit that patient and see not to have the pancreatitis in the near future. So the importance of these lipid profile is very, very important, that to select the drug, to know the dose of the drug, to use the single drug or a combination drug, that will help us by seeing the lipid profile. Statins in the diabetes impact on the atherosclerotic cardiovascular events. See, American College of the Cardiology or the AHA defined 4 statin benefit groups. One of them is the diabetic. See, if you see here the 4 groups which are benefited with your statin therapy: clinical atherosclerotic cardiovascular disease. We are having a lot of the people in our India. All the cardiology departments, all the medicine departments, they are all having atherosclerotic cardiovascular disease. Clinically, all smokers, all diabetics, all hypertensive, obesity, etc. And if you see the second group, LDL-C cholesterol more than the 190. Nowadays, we are not seeing LDL 190 because we are starting the statins from the beginning. Even when the LDL is 100 or 110 or 130, I am damn sure that most of our practitioners, not only in the Kakinada, but also in the peripheries, they are starting the statins therapy and they are not allowing our patients to reach that second group of LDL-C cholesterol more than the 90. I have not seen a single patient nowadays with LDL-C cholesterol more than the 90. And the third group is very important, the diabetics, they need the statin. And the fourth group is also very important, more than the 7.5% estimated 10-year atherosclerotic risk age between the 40 to 75. So if you see these 4 groups that benefit with the statins, an Indian population, they fall into one of these 4 groups. Indirectly, we can say that all Indians, they need statin. Treating diabetic patients with the statins, more aggressive statin management in patients with diabetes, not as just 5 milligrams of the rosuvastatin or the 10 milligrams of the atorvastatin will work for that. When the fellow is a diabetic, uncontrolled, so please start at least 10 milligrams of the rosuvastatin, 20 milligrams or the 40 milligrams of the atorvastatin. That is called as high intensity statins. Heart protection study, if you see the study, lowering the LDL cholesterol by 40 milligrams reduces the risk of the major vascular events by about 1/4. So during the 5 years of the treatment. See what is the benefit of LDL-C cholesterol. So by reducing the LDL cholesterol by 40 milligrams, we are getting about 25% risk reduction in a 5-year treatment groups. So that is very, very important. And the third point is very important, that reduction in the CV events with the statin therapy was similar in individuals with the diabetes diagnosed for a short duration, less than the 6 years, or a long duration, more than the 13 years. Whether the diabetic of short duration or the long duration, if you use the statins, they are all benefited. So the continued statin treatment prevents not only the first attack, but also subsequent major vascular events. So whether you use the sulfonylureas, whether you use the dapagliflozin, whether you use simvastatin, what is that, gliptins, sitagliptin or vildagliptin. So you can change those drugs, but should not change a statin in a diabetic individuals. Okay, so the continued statin treatment subsequently reduces the major vascular events also. So this is the CARDS trial. Diabetic patients treated with the statins, they reduces the acute coronary events by 36%, coronary revascularizations by 31%, and stroke by 48%, death rate by 27%. So the diabetics with the statins, so the reduction of these major events is like that. So you all agree with me that statin is a must for a diabetic individual to reduce all these things. Otherwise, premature death is very common. What about the role of the rosuvastatin in the diabetes dyslipidemia? See, this is the CORAL study. They compared the rosuvastatin with the atorvastatin. So RSV is the rosuvastatin, AGV is the atorvastatin. You see here whether the 6 weeks group or the 12 weeks group or the 18 weeks groups, in all the groups, rosuvastatin scores over the atorvastatin as far as the risk reduction is concerned. So this is the CORAL study. The Uranus study, again the rosuvastatin is superior to the atorvastatin in reducing the LDL-C cholesterol. If you see the LDL cholesterol reduction, that is more with the rosuvastatin when compared to the atorvastatin. So Andromeda study, again they studied the atorvastatin and the rosuvastatin. Again the reduction is more with the rosuvastatin. So in combination with the non-statin therapies in the diabetics. See, statin plus ezetimibe, very, very good molecule, very good combination. Not for all the population, but some population where even though if you use the high intensity statin and if you are not happy with the LDL reduction by 30%, 40%, 50%, 60%, so that is the time you have to add the ezetimibe. This is not the drug combination to be added on the day 1 of your dyslipidemia. On the day 1 of your dyslipidemia, use the statins. Give the good high intensity statins and wait for about 3 months or the 6 months along with your lifestyle measures and the physical activity and cessation of the smoking, moderation of the alcohol, high fiber diet, high fruits diet, etc. And then you see the lipid profiles. Still the LDL reduction is not more than the 25% or 30%. Then you can add the ezetimibe to improve your LDL reduction much better when compared to all the things. So if you see the higher lower is more with this combination when compared to the statins alone. Improved lipid targets achieved in the type 2 diabetes patients with statin plus fibrates treatment. So I told you the mixed dyslipidemia individuals where we are supposed to use the fibrates also along with the statins. Otherwise, again there is a high risk of getting the atherosclerosis. So rosuvastatin plus fibrates in the fixed dose phases. Rosuvastatin 5 mg and the 10 mg. Now the 5 mg plus fenofibrate is available. 10 mg plus fenofibrate is available. I think in Indian population, we need 10 milligrams of the rosuvastatin plus the fenofibrate rather than the 5 milligrams of the rosuvastatin. So they reduce 24.5%, 29.5% about your LDL cholesterol. Rosuvastatin plus bempedoic acid. The same thing happens here also. So after using your high intensity rosuvastatin, still you are not happy with the reduction of your LDL-C cholesterol, then you can add this bempedoic acid along with the rosuvastatin also. So guideline recommendations for the management of diabetes dyslipidemia. So these are 2023 ADA guidelines. See all this here, if you see the maximally tolerated statin plus ezetimibe, maximally tolerated statin plus ezetimibe, maximally tolerated statin plus non-statin therapy like ezetimibe. So now the ezetimibe combination with the statin is gaining up. That is the most recent thing to be happened in the lipid management. So don't be happy with the statin alone. If you are not comfortable with the LDL reduction, you can add the ezetimibe as a plus drug for here. The same thing happens here, ADA guidelines. See, I told you high intensity and low intensity. See here, not low, moderate intensity. There is no place for your low intensity statins in the Indian population. So no low LOW in Indian diabetics. So they need either the medium intensity or the high intensity. Here the high intensity already told you atorvastatin 40 to 80 and rosuvastatin 20 to 40. Whereas the moderate intensity atorvastatin 10 to 20, rosuvastatin 5 to 10. So finally, the management of the diabetes with the foundations is lifestyle modification and the diabetes education. So that's what we are doing here. And then the main 4 pillars are the A, B, C, D. A, B, C, D. A is your diabetes management. B is blood pressure management. C is your lipid management. And D, your drugs to protect the heart and the kidneys, and your dietary approach, your doctor relations, your compliance with the physicians. So these all comes under the D. So this is how we have to reduce the diabetes complications to have a good quality of the life. So these are all the recommendations. The statin is the first line of the drugs. Guideline recommendations also the same. The diabetes without atherosclerotic cardiovascular disease, diabetes with atherosclerotic cardiovascular disease. Again here, if you see the high risk individuals, LDL goal is 70, less than the 70. If you take the very high risk individuals, the LDL-C goal is less than the 50. See, diabetes without atherosclerotic cardiovascular disease. Only pure diabetics, no atherosclerotic cardiovascular disease, but they are the high risk or very high risk, even the less than the 50 is needed. And if you see the diabetes with atherosclerotic cardiovascular disease on the second side, if you see the last one, red one, extreme risk individuals, LDL-C goal is less than 30. So that is the most important thing. So don't be happy with the LDL cholesterol of 80 or 90 or 100 or 70. Achieve the 50 or the 30 possible without the side effects, without the rhabdomyolysis or without the muscle aches or without the statin intolerance, etc. So you can achieve these things. The same thing here. Role of multi-specialty care. So here for a lipid management, you need not refer the patients to all these 4 population. So the primary care physician, cardiologist, endocrinologist, nephrologist, you should behave like all the thing. So as you are interested in the lipids management, you know what is the statin, you know what is fibrate, you know what is ezetimibe, when to use, when not to use. So definitely you are a combination of a lipidologist or a cardiologist or endocrinologist as far as the lipid management is the concern. So a multidisciplinary diabetes complication clinic is ideal, but all clinicians should be able to manage the lipids, manage the sugars, manage the blood pressure, and obviously you are giving very good care. So finally, a secondary causes must be also ruled out. So before you blame it, lipids, so this is a hypothyroidism is a very common secondary cause. So see the TSH level, if it is more than the 5, subclinical, if it is more than the 10, it is a established hypothyroidism. Of course, even at the 6, whether if you are T3 and T4 at a lower level, again it is an established hypothyroidism. So here you have to use the altroxin in the doses of about 1.6 into your body into kg body weight. So that is the doses of your thyroid supplementation of the hypothyroidism. Nephrosis, your nephrotic syndrome, where there will be the dyslipidemias. SLE, multiple myeloma, they have progestin or the anabolic steroid treatment, mostly your hormonal therapy. Cholestatic diseases, yes. Protease inhibitors in HIV therapy. So HIV therapy also they have a lot of the dyslipidemias following the heart therapy. CKD, they are the dyslipidemic, type 2 diabetes, obesity, excess alcohol intake, more triglycerides, antihypertensive medications, especially the diuretics, beta blockers. So when you are using the atenolol or metoprolol, so they cause dyslipidemia. If you use the bisoprolol or if you use the nebivolol, so they don't cause any dyslipidemia. In the same, if you use the diuretics, again they cause dyslipidemia. So these are the very important. If you use the finerenone, so last time we discussed about the non-steroidal mineralocorticoid antagonist, so that is lipid friendly. So steroid therapy, so definitely. So these are the very important secondary causes of the dyslipidemia. So as a good physician, you should check for the secondary causes and treat these secondary causes. Then your lipid profile will be the normal. So thank you very much for your patient hearing. And if you have any doubts, I will be very happy to clear.